It's unfair for the patient if you're giving an opinion about a spine operation if you don't currently or have never done any spine operations. As a doctor, you need to be unbiased. That is the most important thing. Like the opinions I give would be exactly what I would do for my patients, both in the public and private sector. There is no change.
Welcome to The Consult by Australian Specialist Hub, where medicine meets the law, and we discuss some important topics with our experts and how that impacts with their medico-legal work. Dr. Ameya Kamat, lovely to have you here.
Thank you. Thanks for having me.
With over a decade's worth of experience in medico-legal, do you want to give me a little bit of a background of where you started and then how you ended up in medico-legal work?
Absolutely, yes. I went to med school in South Africa. I finished high school very, very young. So I finished high school just after my 14th birthday.
Wow.
So then did a degree first in biology in a combination of the Caribbean and the States. And then kind of figured I was a bit too young to be working full time. So I thought I'd try my hand as a doctor. So I went to med school in Johannesburg, South Africa, and did my spine fellowship did my training there as well, did my spine fellowship in Sydney. And then it was around COVID time, and obviously I was looking for a consultant job, and there were none. There were no consultant jobs in the entire country. However, one of my colleagues who I worked with previously in New Zealand had a contact in Darwin. And he's like, well, you should approach this chap. He may be able to give you a job. So I phoned him saying, I'd love to get a job in Darwin. And he said, oh, listen, we don't have any jobs at the moment. I've got a guy from the UK coming, so we're actually full, but if there are any changes, I'll let you know. I'm like, no problem. Anyway, COVID came, the borders were closed. The moment the borders were closed, I phoned the same guy saying, hey, I know you've got a chap coming from the UK, but the borders are closed. I'm in Australia. And he literally asked me, when can you start? And literally a few weeks later, I was in Darwin, and I'm still the director of neurosurgery for the Northern Territory.
Everything happens for a reason.
Everything happens for a reason, yeah. Exactly.
What's your favourite part about working in Darwin?
The variety. I think there are two main things. One is the variety of pathology that you see there, from the brain and spine infections to the degree of trauma, the cancer patients, the degenerative stuff. That you can actually make a massive difference to people there. And also people, I've realized, in the Northern Territory are so grateful. They have so much gratitude. They're just so happy that you're there providing high quality healthcare. And our unit in Darwin only started in 2017. So before that, all patients for any neurosurgical procedures that were elective had to be sent to Adelaide.
Wow.
The general surgeons were doing some of the emergency brain trauma. People don't need to travel far away for medical care anymore. And obviously, we're being the custodian of the taxpayers' money. We're saving a lot of taxpayers' money also, but not having to send people and their families interstate for treatment that they deserve. The people in the Northern Territory pay tax like the rest of us do all over the country, and they deserve to have a high-quality health system in their home state, and that's what I'm pushing for.
We were just having a conversation earlier that a lot of people, when they're looking for a medico-legal expert, they think, neurosurgeons, brain and spine, but there's actually so much more to it.
Absolutely. So, we handle so much more. There's the brain, there's the spine. We do tons of pain procedures as well, brachial plexus injuries, peripheral nerve injuries. There is a bit of overlap with plastic surgery for brachial plexus and nerve injuries. And not all neurosurgeons and not all plastic surgeons do both, but there's a whole host of us who do that sort of stuff as well.
What does a typical month look like you through Australian Specialist Hub? The states you cover, the types of matters, and the kinds of cases you're seeing?
Yeah, so most of what I do still, given I'm still pretty young for a surgeon, I do a combination of clinical medicine in the public and private sector, and obviously medical legal work. The majority of what I do, I'd say about 80 to 90%, is still clinical medicine, and I think that's really important because you need to keep current. If you're going to talk about an operation that someone may need or may not need, it's best to have experience doing that operation so you can actually give an expert opinion on that. With Australian Specialist Hub, obviously, I work a lot of work with you guys in New South Wales, Canberra, Tasmania mainly. I do some work with Victoria also. I try and do about 4 to 5 days a month with you guys, and so far it's been awesome. You've got a very friendly team. Communication is excellent. Dealing with you as the director directly is so easy.
What is something in the medical legal space that is consistently misunderstood? Something you would like to set the record straight on?
I think the most important thing is that if you're doing a report for an insurer or you're doing a report for a plaintiff firm, as a surgeon, as a doctor, you need to be unbiased. That is the most important thing. At the end of the day, I would personally never trade my integrity. I think you summed it up a while ago, cash for comment. That's not what I do. If someone's looking for that sort of expert, I'm not the guy. Certainly, I would treat my patients, and whether, like the opinions I give would be exactly what I would do for my patients, both in the public and private sector. There is no change. If I see a patient in my rooms or in my public hospitals who need a certain operation or don't need a certain operation, I would have my report based on that. Because at the end of the day, I want to treat all patients the same. And you can't expose a patient to unnecessary risk or deprive them of treatment just based on who's sending you a request for reports. I think integrity is number one. Without that, we have nothing.
Absolutely. And one thing about how you run your assessments, you actually walk out to the patient sitting in the waiting room and introduce yourself and say, hi, I'm Ameya, I'm your neurosurgeon.
Absolutely.
Come through.
You get more from people if you make them comfortable, if you make them feel that you're a human as well. At the end of the day, that's all we are, right? I'm a neurosurgeon, you're a patient, but we're the same. So if you can treat someone like normally, I introduce myself by first name. I think just keeping it at a human level, I think that's really important.
The small details, it makes such a big difference.
Big time, yeah.
And you're dealing with a lot of people where pain is a central part to the case. Do you want to tell me a little bit about neurosurgeons and assessing pain?
Yeah, sure. So the pain obviously is something we all experience, and humans weren't meant to have pain. But the problem is, when you have pain, it can affect your mental health, it can affect everything. And when you've had pain for a while and now it starts affecting your mental health, for example, it can delay and hamper your recovery. That's why I've realized patients who I operate on in the public and the private sector sooner with a problem do better than those who are waiting 1, 2, 3, 4 years for an operation. So I think reducing that delay and addressing their problems in a timely manner is, I think, really important. Yeah.
Do you have any tips or tricks for our referrers when producing their letters of instruction?
Yes. I think the questions should be clear and concise. That's really important. Sometimes there's repetitive questions, or they ask the same question in multiple different formats, and that can cause a bit of confusion for everyone. Also, having documents sent in a chronological manner makes a big difference. Sending the GP's notes are really important. If someone comes in, for example, with lower back pain, and they've had a work injury, but then they tell you they've never had back pain in their entire life. But then you look at the GP notes, and they've been presenting to the GP every 2 or 3 months with back pain for the last decade. Clearly, the condition's pre-existing. These things make a massive difference. So GP notes, ambulance notes, all that sort of stuff is really, really important. If they've had any operations before, that's really important. And for me, where they've had their scans done, because as a surgeon, if I'm planning something, it's like if you're a pilot, do you want your pilot flying your Qantas A380 to read the actual flight map and flight path themselves, or hear about the flight path? Think about it, right? You're trusting your life in their hands, sort of thing. So similar situation, like for me, I want to look at a scan. If I'm going to plan, if I need to say someone needs surgery or doesn't need surgery, I need to look at the actual images. So you don't just send me a snippet of the report. Tell me exactly where the scan was done. I will chat to the patient to ask them if they're happy for me to look at the imaging, and that way, if I can look at the scan, I'll have a much more in-depth report for you based on the actual images, and that makes a massive difference.
Absolutely. Neurosurgeons being known for their extensive attention to detail,
Exactly.
I would wanting them to look at the report themselves.
Exactly. It's hard to plan an operation based on the radiologist's words. Also, remember, many radiologists, and I mean, not all radiologists, but many of them are general radiologists, right? And they're giving you a report, but the actual nuances, the actual details on the scan sometimes are not being demonstrated in the words. And often we pick up things on the imaging that the radiologist has not commented on, because we look at spine and brain scans all the time. A radiologist will look at scans of the arms, the legs, the brain, the heart, like the works, the abdomen. Whereas for us, we're so specialized with brain, spine, peripheral nerves, we can pick up things that the radiologist can't, because that's kind of all we do, looking at scans and treating patients with these pathologies. So looking at the actual images, we often, there's so many occasions, Hannah, where I pick up something saying, listen, clearly there's a problem here that's causing the patient's pain, and you can deal with it, as opposed to just quoting a radiology report that is accurate, but may lack that attention to detail.
Is there any particular cases or particularly challenging cases that you've had recently?
Absolutely. I think the most challenging ones are the brain trauma cases, because often patients have no recall of the event. and we're reliant on the ambulance notes, their family, like witness it's a witness who may have documented something. So it's hard to actually gauge that. And then also when you're assessing them, they may act like everything's completely fine, but when you delve deeper into their pathology and ask them more questions, then you actually realize that there is a problem there. So in those cases, having things like a neuropsychology report is really important, because the neuropsychologist can spend 2-3 hours with them, run a whole battery of tests, and that gives us a lot of information that it's hard for us to extract in like a 1-hour consultation.
Oh, that's really important, because I think that the order of the reports are gathered can differ between different solicitors. There's different sort of methods to what they're doing. So it's good to know which ones are needed in advance, particularly I think between allied health and your neuropsychologist and also your occupational therapist.
Yes.
So in your opinion, you would prefer to have those done before the patient sees you?
Absolutely. I mean, if possible. In an ideal world, yes. I mean, it doesn't have to be the case, but, ideally, yeah. Yeah, for sure.
It also sounds quite terrifying for that person having an extensive injury and having no knowledge of it.
Yeah, no, exactly. I mean, and I think it affects their life so much. I mean, you have someone here who's fully functioning, like prior to the injury, and now they've had such a horrendous brain injury, they've had brain surgery, and their lives not the same. And they don't know. It's like the unknown, right? They've had an injury, they don't know how bad they actually are, but they know that they're not coping, but they can't express themselves.
Now, there's one question we get from clients all the time, and I'd love for you to settle it once and for all.
Sure.
With a spinal injury, when does it go to a neurosurgeon, and when does it go to a spinal orthopaedic surgeon?
All right, so before I answer that question, I've got to just talk to you about our actual training program, right? So as neurosurgeons, our training program before we actually get on, after we get on the training program, it's about 5 to 6 years in length. We do spine surgery from day one. So by the time we're done with being a neurosurgeon, or done with that training,
so you're knife to skin from day one?
Well, yeah, because you're operating, right? So so we learn how to deal with brain and spine conditions from day one. So we have an extensive spinal surgical training program, which is part of our general neurosurgical program. So by the time we're all done, pretty much every single neurosurgeon in this country can do spine surgery. With orthopedics, however, they have different rotations as well. So they'll do spines, they'll do hips, knees, ankles, upper limbs, so on and so forth. So not all orthopedic surgeons can do spine surgery. So the issue I've realized is often you have a foot and ankle orthopedic surgeon who's commenting on spine surgery. And now let's just say this surgeon is in their 60s, for example. The last time they did a spine operation was probably like 30 years ago. And they're commenting on whether a certain operation is required. Often in their reports, some of them will comment saying that they will comment on the operation, but some will be like, well, this is out of my scope of practice, and I shouldn't be commenting on this, which is fair. Same way you wouldn't want a neurosurgeon commenting on a foot and ankle problem or a wrist problem, right? So if people refer to an orthopedic surgeon, they need to have spine background. You can't refer to a general orthopedic surgeon who doesn't do spine surgery. So I think it's really important for case managers and lawyers alike to actually ask the orthopedic surgeon in advance, do you do spine surgery? When was the last time you did spine surgery? Because it's unfair for the patient if you're giving an opinion about a spine operation if you don't currently or have never done any spine operations. With regards to your question about a spinal orthopedic surgeon and a spinal neurosurgeon, so things like fractures or degenerative conditions can go to either or. There's no issues there at all. Things like pediatric scoliosis, like medical negligence stuff around those lines, that's probably better for an orthopedic surgeon because they do more of that than we do. Certainly, if I had a complex pediatric spine with a scoliosis, for example, I would refer that to an orthopedic surgeon over a neurosurgeon because more of them do that. Okay. With regards to degenerative things or complex spine in general, it doesn't matter who you send them to. However, if there's a spinal cord injury or any spinal tumors that involve the spinal cord or spinal nerves, that's probably better dealt with by a neurosurgeon.
Okay.
Yeah, so that's the overlap there. But I think, to summarize though, you need to refer, case managers, lawyers need to refer to people who are either current or have done those operations. It's not really fair for the patient referring it to someone who has never done that operation or it's been 20 years since they've done the operation.
So I had a lawyer say to me the other day that anything lumbar goes to the spinal orthopedic and anything above that then goes to the neurosurgeon, which I thought was interesting.
So I do about 500 to 600 spine operations, brain and spine operations a year. And I probably do more lumbar operations than cervical operations just because more people have lower back pain than neck pain.
Okay.
In the practice I've seen, but other surgeons may have it the exact opposite. I don't know.
Okay. It's just an interesting way to triage the case.
Yeah, exactly. Yeah.
What inspired that sort of nature?
Yeah, so I mean, I've realized that most people don't need operations, right? And that's what I'm saying. I still do about 500 operations per year, so I still operate a lot. However, I see a couple of thousand patients a year between my public and private practice, and I'm a firm believer of trying to exhaust conservative management first. And that's how I see it from a medical legal standpoint as well. If somebody comes in and they've got pathology that may be responsive to conservative treatment, that's how I would normally recommend saying exhaust conservative treatment prior to operating. I mean, there's some cases where if someone's got clear weakness or spinal cord dysfunction, that's obvious. There's no room for conservative management, they need an operation. But I would say the vast majority of patients can get away without an operation. And you know, I try and see patients in the medical legal sphere in a similar way that I do in my own public and private practice, because humans, and most people can get away without surgery. Yeah, but obviously it's a case-by-case situation, right?
Very much case-by-case in medico-legal.
I just try and be like a normal person, right? And whether I'm talking to a case manager or one of my colleagues or a patient, I just try to be normal, make people feel comfortable, treat people with respect, treat people with like dignity. I think just normal human values that we should all have as people.
Absolutely, yeah. Sounds quite simple.
Yeah, exactly. No, I think so. I'm just be yourself, and everything takes care of itself.
Yeah. What did you want to be before medicine?
A pilot.
Could still be a pilot.
I still can, but my wife has blocked that now. So yeah, because if I'm a pilot now, it'll probably be one of those small planes and high chance of crashing in her head. So but I've always wanted to be an airline pilot. I think it would be awesome because I love traveling. It's my absolute passion. Yeah. I've traveled to over 102 countries now. So
wow.
100%, like no doubt about it.
Flying around the country doing IMEs. Yeah.
Why not? The world maybe eventually. Who knows?
What does a neurosurgeon do to switch off?
I love, again, traveling, food, wine, friends, family. I think those are my favorite things to do. Yeah.
Fantastic. What is one thing people get completely wrong about neurosurgeons?
I think they think that we are very serious, very nerdy, very like spend a lot of time with like doing research and being book smart. But I think that's the old generation. I think like now most of us are like just like normal people. We have like similar interests. We just like doing fun things, and we kind of have life as well. You know?
Yeah, it's changing for the better.
Yeah, absolutely. Yeah, I think lifestyle. We're certainly not as like previously neurosurgeons would be working 70, 80, 90, 100 hours a week, spending 15, 16 hours a day in theatre. We still do long operations. We still work really hard. But we also like try and have a degree of work-life balance. We're probably not as balanced as other specialties, but we try.
I always thought the comment about, it's not brain surgery.
Oh, no, that's it's definitely not just brain surgery. Yeah, actually, that still stands. I mean, it still is very complex. It's definitely harder than most things, but we are highly trained. After you finish high school, it takes about 16 years to get to where we get to. If you think about, going to med school, internship, doing other specialties for a while, registrar time, training times, fellowships after, it's definitely a lot of work, a lot of dedication. There's no doubt about that, but
wow.
Totally worth it.
That's a long 16 years.
It's a long 16 years,
yeah.
But like blood, sweat, and tears. But I'm so happy that I've achieved what I've achieved, and I'm trying to live my best life.
Yeah, was that always the dream for you to go into that area of medicine?
I always wanted to be a surgeon. There was no doubt about that. I wasn't sure between neurosurgery, orthopedics, plastics, or general surgery. In fact, I thought I was going to do orthopedics. I did about a couple of years of orthopedic surgery, and I loved it. I really enjoyed it. But then I started liking spine surgery a lot more. So I thought I'll do a 6-month rotation in neurosurgery because I know that the neurosurgeons handled the spine really well. First time I saw the brain, I'm like, this is it.
This is me.
Yeah, that was like a light bulb moment for me. I'm like, wow, and I haven't looked back. I mean, I can probably say, although I got into neurosurgery and orthopedics, wanting to do probably more spines, after seeing the brain, for me, that was it.
That was it. And so life-changing for
yeah,
someone
absolutely.
who's so young.
Most of what I do is still spine surgery because of the volume of spine surgery we have. But I do love I do love brain surgery, brain trauma, brain tumors, that sort of stuff. Yeah.
That was going to be one of my questions, brain or spine.
I think in terms of enjoying operating, definitely brain surgery, but obviously we see a lot more spine these days, so it's just part of our practice, right?
Yeah, absolutely.
Yeah. I think most neurosurgeons went into neurosurgery for the brain, I think, but then we just evolved to be doing more spine because of the sheer volume.
And the cohort of work injuries coming through is an enormous amount of
absolutely. Work injuries,
Yeah.
motor vehicle injuries. The thing is, people are living longer, and when people live longer, they're going to get more back problems, more neck problems, and these things do require attention. Be it pain blocks, radio frequency ablation, surgery, all that sort of stuff.
Absolutely. And we've got Men's Health Week coming up as well. So that was a cohort I wanted to ask you about, if that's sort of where you're seeing a lot more of particular types of injuries with the amount of workers that you're seeing in that sector, and just get a bit of view on men's health and neurosurgery.
Yeah, so I think from a men's health point of view, many of the trades right now obviously employ a lot more women as well, but I think they're still majority male driven. And most of the people who work in these environments, obviously like the tough tradie types, like nothing phases them, which is awesome, like man's sort of thing. But unfortunately, that's where they get injured, right? And they get horrendous injuries, and then they don't know how to cope with those, because they have pain, they go through the whole work cover or the motor vehicle processes. It takes so long, it affects their mental health, and it's a massive problem. And I think just getting treatment earlier is the way to go, sooner.
Absolutely, and encouraging people to speak up and come forward, and not that tough it out sort of
exactly.
mentality.
And I see so many people who have a work injury and they're I'll be fine. I'll just walk it off. It's probably muscular strain. I'll be good. 8 months later, they're still not good. It's the human spirit, though. Isn't it? You've got a young family. You just want to keep providing for them.
Yeah.
Look after yourself. Live your life. Stop complaining. Just do things. That's the mentality, which is awesome, which is great. But the problem is, at the end of the day, it takes a toll on your body.
I think experts are put in a position where sometimes they have to make some very, very hard calls.
Yeah, exactly. And sometimes we don't have the answers. I mean, and there's some cases where you just don't have a diagnosis. So it can be a challenge.
And on top of that, we've got a different scheme in every state,
Yes.
with different impairment guides.
Absolutely.
So your job is very complex.
Yeah, no, absolutely. Yeah. I mean, I know like Vic Taz is AMA 4, everywhere else is AMA 5, but then the New South Wales motor vehicle is AMA 4, and then the Northern Territory is AMA 6 for motor vehicle. So it can be a bit confusing, but I thought one country with 27 million people, it'd be nice if we had one simple system, but that'd be too easy, right?
No, exactly. It's a bit wild, but we do our best.
Yeah, exactly.
Yeah. I know you covered. I was going to ask you what your favourite part is about working with Australian Specialist Hub, but you beat me to it.
Yeah, no, yeah,
You got that
exactly. I
bit.
mean, I think the most important thing for me is dealing with people, right? Like at the end of the day, there are so many different medical legal firms out there. For me, the communication is the most important thing, and I like to pride myself on being a good communicator. I dictate my reports there and then. I'll see a patient because I don't have the attention span to dictate a letter 6 weeks later, and I'm going to forget. It's all about being thorough. It's all about getting everything out there as soon as you possibly can while it's fresh in your brain. And I literally dictate there and then. I send a copy. I send a copy of that to Linda and to your generic email address. 30 seconds later, Linda said received. So now I know it's been received. I've worked with other companies in the past where you send them an email with the dictated file. You never know if they've received it or not. And then 3 weeks later, you forget because you've seen so many patients, and then they ask you, oh no, dictation for John Doe is outstanding. I'm like, no, it's not. I sent it to you literally 15 minutes after seeing the patient. So for me, the communication thing is number one. Everything else is secondary. And dealing with you guys is always awesome because you're very good communicators. You're easy to deal with. You're nice to talk to. I've had no major dramas, and if I've ever had any concerns, which as humans we always do, I just bring it up with you, bring it up with Linda or Caitlin, and it's all sorted within seconds.
Straight away. No, thank you. You dictate it straight away,
Yeah,
and then we're usually getting it to them within days, not weeks.
Yeah, exactly.
So.
And I think if you think about it from the patient's perspective, especially if it's a decision on surgery, like I've had times where I'll get a report saying the patient has a surgery scheduled for 2 weeks. And if you send them the report 3 weeks later, they've missed the surgical date, that surgeon's busy, they've got to reschedule the patient. Whereas if I do my dictation there and then, it's typed up within 24 to 48 hours, I look at the draft, send back to you, they get it within 3 or 4 days, they can communicate with the surgeon saying, hey, listen, surgery's a go. And that patient has the operation weeks or months in advance.
Dr. Kamat, this has been a genuinely valuable conversation. Thank you so much for having on the consult.
Thank you so much for having me. It's been awesome.
Wonderful.
Okay, cool.
Amazing.